Ladies and gentlemen, welcome. Tonight we're exploring the crucial topic of physician burnout and how AI may help or hinder the issue. To begin, we're honored to welcome a speaker who has been a key figure in addressing healthcare challenges nationwide. Please join me in welcoming Dr. Chris DiRienzo, Chief Physician Executive at the American Hospital Association.
Good evening, everyone. Good evening. And to those who are joining the live stream, my apologies. You're missing out on what is a spectacular line at the back here. It's a wonderful event this evening. I am so grateful to get to be here. I'm but the warm-up act, and I promise to keep my comments less than 5 minutes. I'm Dr. Chris DiRienzo. I'm proud to serve as the Chief Physician Executive of the American Hospital Association and as the president of our 501c3 entity, HRET. I'm also proud to be a neonatologist, and this Friday I get to go round on teaching rounds in the Duke NICU, which I get to do still about once a month, but most of my time I spend on the road. And I've been with the association now almost 2 years, and in those 2 years I've visited 34 states, and I've racked up about 500,000 frequent flyer miles on American Airlines, which makes me increasingly popular with members of my extended family who I've never actually met. I visit hospitals here in Manhattan that are over 1,000 acute care beds, and I visited more than one hospital where I've had to drive a dirt road through a cornfield in order to get to a place that has a census of 2, a medical staff of 4 full-spectrum family practice docs doing great work, and even once I had to park in a parking lot that was shared with the town's baseball field. And you don't get much more central to your community when your hospital shares the parking lot with the baseball field. But I do all of that travel because my job is to spend nearly every week somewhere else in this country meeting with physicians and hospitals and their leadership teams and talking about what's top of mind. And it comes as no surprise, certainly to those of you in the room, that top of mind all over the country is the issue that we get to engage around tonight, AI, and specifically its impact on the burnout of our workforce. It's no secret that we are in the midst of an historic healthcare workforce crisis, and our clinicians are burning out at alarmingly high rates. It's especially poignant to bring that up today, because today is a day that we recognize as National Physician Suicide Awareness Day. Finding solutions to these challenges is not only a top priority for the AHA, it is a top priority for health systems everywhere. And I mean everywhere. Rural and urban, investor-owned, nonprofit, community, academic, large, and small. Why? Well, you and I both know that technology is increasingly core to our experience of healthcare. But it's also true that when we leave technology to its own devices, it becomes the risk. We run the risk of technology really being an orchestra without a conductor. But friends, I'm here to tell you this evening that all over this country, there's an increasingly diverse group of conductors who are using this technology to make some pretty spectacular music. And they're doing it in big systems, they're doing it in small systems, they're doing it in the Northeast and the Southeast. I hear routinely from members, multiple states, multiple different solutions, who their early pilots of ambient listening are reducing time in their EMR for docs by 40 and 50%. I hear from others on the West and the East, the North and the South, who their inbox management, those AI-generated responses, are getting acceptance rates of upwards of 80%. And you all are about to hear from a panel who I am certain are going to have stories that are equally, if not more, impressive. Just remember, we're also walking through this together at a time that AI regulations are shifting in this country and across the world. But the EU regulations that approach our field, approach AI with a sliding scale of risk, are law today. And they will increasingly go into effect from now through 2026. What that means that we've got some decisions to make. Some decisions about how to harness the currently unknowable power of this technology to transform nearly every aspect of our practice with how much risk we're willing to tolerate. And frankly, folks, that's what we're here to talk about tonight. I am but the opening act. You have a group of panelists who are truly incredible, and a moderator who is a spectacular editor. What they're here to talk about and to remind all of us is that healthcare is and will always be a uniquely human experience. That's why we need these kinds of conversations. That's why we need experts like you and panels like this, because we cannot fail to thread that needle of technology with the fibers of our humanity. So with that, I am 7 seconds over. Doesn't get that much better. I would like to thank the folks at Newsweek. You have put together an incredible event to kick off your fall series. Thank you so much for bringing us here this evening, and please put your hands together for what will be a spectacular panel. Thank you.
Dr. DiRienzo, thank you for setting the stage for tonight's conversation. And Hospital for Special Surgery, thank you for sponsoring tonight's event. My name is Alexis, and this evening I have the special privilege of serving as your moderator. Please take a moment to silence your cell phones, if you're able, and please do hold questions until the designated section at the conclusion of our panel. Folks, we are in good company tonight. I'm joined on stage by an outstanding group of thought leaders in not only healthcare AI, but also physician well-being. All four have a personal connection to this topic as technology innovators or implementers, but also as medical doctors themselves. Dr. Clardy, Dr. Sinsky, Dr. BC, and Dr. Williamson, thank you for being here. So let's start by breaking down burnout. There are a number of physicians in the room with us today who are probably well aware of that term. If you made it here without charting or checking your email on the commute, congratulations, you are ahead of the curve. For many doctors, that workload, it's never ending. Christina Maslock and Michael Leiter, pioneering burnout researchers, have defined burnout as a psychological syndrome emerging as a prolonged response to chronic interpersonal stress on the job. I'm tired just reading that. Symptoms include exhaustion, cynicism, detachment, and feelings of ineffectiveness. And burnout is very common among US physicians, with nearly half of doctors reporting at least one of those symptoms in 2023, according to the American Medical Association. But the term burnout does not resonate with everyone. So Dr. Sinsky, how would you define burnout? And why do some physicians reject that term as a descriptor of their experience?
Yeah, thanks so much for that question, Alexis. So you gave the formal definition of burnout: emotional exhaustion, you're just tapped out, depersonalization, disconnected from the person with whom you're caring, for whom you're caring, and then that feeling of powerlessness and cynicism. That's the formal definition. But I like to think of it as this disconnect between the mission of our work, the reason that we went to medical school or nursing school or whatever professional school, and the content of our daily work. And it's that disconnect, that feeling that we are spending our days doing the wrong work for our patients, that is really at the heart of burnout. And then to your second question about why do some people, and I would say, why do some physicians really reject that term? And I think some people feel judged by that some physicians feel that that's putting the locus of responsibility on the individual. And so my response to that is, while burnout manifests in individuals, it originates in systems. And it's the systems that are broken, not the people within.
Certainly. Keeping that in mind, for doctors who do resonate with the term burnout, we have some hope on the horizon, perhaps, in AI. They cite administrative burden as a leading cause of that burnout that they experience. MyChart messages, prior authorization requests, I'm sure you all have a hefty list of things that make your day-to-day life harder and take you away from clinical care. Dr. BC, what AI initiatives have you implemented at New York Presbyterian, and how have your physicians responded to those in their day-to-day lives?
Yeah, that's a great question. As it relates to physician burnout, we're evaluating a couple different types of technologies. One is a virtual scribe, another is auto-generated in-basket messages. And our physicians so far have had positive reception to it, right? They think that it does reduce burnout and reduce mental fatigue. What's interesting, what we're seeing is that the actual time calculated for the task is not as reduced as much as we thought it would be. And I think that's fascinating, especially because when we poll our providers, we're seeing that their perceived time on the task is reduced. And so I think that really demonstrates that it's the reduction in mental fatigue due to changing a task from writing and having the inertia to start it to now an editing task. Physicians also think that there's more empathy in the responses. There's some improvement needed to have brevity in the responses. So overall, I think that we're moving in the right direction, but that there's room for improvement to really meet the needs of providers and hospital systems in the long term. And second, that we may need to look at metrics outside productivity, such as the cognitive burden and other things to really show value.
Certainly. And Dr. Williamson, you're implementing AI tools at Mayo Clinic as well.
Yep.
What are you seeing?
Honestly, our experience is very similar to Ashley's experience. When we look at what has been implemented, frankly, a lot of the tools, I'm a radiologist, so a lot of the tools that I look at are imaging based. And a lot of them are pretty simple and straightforward, right? Take a task that previously took a human, whether a fellow or a resident or a staff radiologist, drawing circles on a particular image, and then automate or semi-automate that task and allow the radiologist, as Ashley mentioned, to move from a generative, I'm going to be the one who is doing this task, to an editing function, where the task has been done for me and now I need to make some little changes. It's super interesting that the perception of benefit, right, and the perception of reduction in cognitive load often exceeds the actual reduction in cognitive load. And we've looked at this, as you guys have as well, when you look at the actual gain in time versus the perceived gain in time, it's pretty impressive, frankly. The perception is that this tool is helpful to me in a way that isn't necessarily borne out by the numbers. But again, maybe it has to do with that shifting of the task and the reduction of the perceived meaningless clerical task, right? And what's, I think, replacing it then is considered to be more meaningful work. And frankly, that's probably one of the keys, Chris knows better than I do, to moving away from burnout and using these tools to move away from burnout, because we shift tasks that are perceived low value and replace them with tasks that are perceived high value, whether that's actually borne out by the numbers or not.
Interesting. Dr. BC, you mentioned that we might need different metrics to measure how these tools are successful, and that physician feedback could inform that. And Dr. Clardy, as Senior Clinical Specialist at Google Health, you're really on the front lines of AI tool development and refinement. How do you incorporate physician feedback into the work that you do to ensure that the tools are hitting the pain points that they need hit?
Yeah, first of all, thank you. And you know, I bring sort of three lenses to my work. One is as an ICU physician and critical care doc. One is as an educator, sort of thinking about concepts like cognitive load and how we can simplify and sort of help transform information for better understanding. And at Google, the teams that I work with are really focused on developing platform capabilities that help with transforming data in ways that are useful to end users. That might be clinicians or other healthcare workers. I think that we do this in a number of different ways. In some ways internally with folks who have experience kind of working in healthcare, understanding use cases and some of the complexities of care delivery and information presentation, but also through partnerships with organizations large and small to try and see whether some of these tools, and it involves a range of things that range from fairly simple machine learning tools to much more complicated generative tools. And there's a spectrum of maturity for different types of tools, but I think anything that comes from the tech side should always be considered a piece of a solution, not a solution in and of itself. And that I think that really the opportunity is to match these tools to workflows that currently carry this very, very high operational burden of making the provider the person responsible for moving this incredibly complex set of data around and organizing it for understanding. So a long way of saying, I think we do some of that internally. This question of evaluation for certain sorts of tools, like search tools, is pretty well established, or for certain kinds of computer vision tools, do they do well in saying something is present or absent? But we're now dealing with a whole new generation of tools that are focused on generation, meaning a paragraph summarizing a patient's hospital course or a condition. That's a very new sort of challenge for evaluation, and knowing that that's good or useful or usable in a clinical setting really requires a lot of partnership to develop these tools.
Absolutely. So in these conversations that you're having with physicians and health system partners, I'm curious, what are some of the common compliments that you receive on the technology, and on the flip side, some of the complaints about how it needs to be refined?
Yeah, I think it's a great question. I think one of the ways that healthcare is sometimes perceived as being slow to adopt new technology. I would say that's refracted in my experience and opinion through two different things. One is that to be clinical grade means something very different from something that is an interesting tool for idea generation. So I think one reason that sort of the new shiny thing might be resisted is that there's a lot of risk when it's involved in sort of care of other people. The second is that we all as clinicians live on such razor thin margins in terms of our time and attention. Anything that breaks a workflow is going to be resisted. Even if it might lead to a better workflow, people have whatever the opposite of time is. So that's the biggest challenge.
Absolutely. On the topic of time, many AI tools promise to improve efficiency and give time back to physicians, which theoretically could allow them to spend more time with each patient or even work fewer hours, if any of you could imagine that. But access is a concern for many healthcare organizations, and frankly, so are finances. So saved time could be filled with more patient visits. You know, how can health systems use AI time savings effectively to meet their strategic goals while not increasing doctors' caseloads and filling that empty time with more patients?
And that's for any of us.
Anybody.
You can see us all
Any
moving.
takers?
Yeah.
Right.
No, I'll take a stab at that actually, because I
Absolutely.
think it's the same question we ask about any other source of efficiency. And it's my contention that most physicians in most specialties and in most settings can save 3 to 5 hours a day by re-engineering the way the work is done and by more strategically delegating that work to an upskilled staff. And that's before we add the AI efficiencies. And my suggestion is we give an hour of that back to individual patients so we can give them more of our undivided attention. That's where I think our diagnostic and therapeutic gold is, and we've marginalized our undivided attention to something that's almost non-existent now. Give another hour of that back to the organization to help improve those workflows, to help improve the organization function as a system, and then give an hour back to the individual for their personal life, for their family life. And there's so much opportunity to use that saved time well. Some of it can be to increase access to the people in your community who are currently not able to access care. And then some of it has to be to make the system work better, and some of it has to care for the people caring for the patients.
I would also add to that, first off, I think the power in AI is not just in doing things faster, but it's doing things right and doing them right in a better way. And so when we think about the visit, to build off of what you've said, Christine, you know, physicians can delve in deeper. They can tackle complex issues. They can actually cover preventative care. And I think this is going to improve quality of care as well as the patient experience. And Alexis, you mentioned access. Access is a huge challenge, right? And something we have to do. We have to be able to see every patient that wants to be seen at our hospital. And AI is a way that can help us do that without, it shouldn't just be the responsibility of the provider though. When you think about access, it's a patient calls, then they get scheduled, then they go to provider visit, and there's an entire workflow for which we could use technology to actually meet some of the needs of that challenge and optimize the work.
Yeah, I agree 100%. The honest truth is that most of the AI algorithms that the FDA has cleared to this point don't have reimbursement associated with them. So we get it, right? We absolutely get that there's going to be a drive toward increased efficiency, which is going to mean more patient visits or whatever, which is all fine, right? And as we talked about, as long as the time savings can be allocated appropriately, and again, as long as the shift in what's being done by the provider allows for more meaningful patient interactions, right? We know that that's where joy comes from within the workplace, and we know that that's how people who are providing for patients, we know that's where they get their satisfaction. I honestly don't have a complaint about the length of my day. My complaint is what I'm doing with it, right? And there's an opportunity for us to fix that.
Yeah, I think that in some ways the time that I'd like to claw back in a way is the difference between looking at a screen and looking at another person. Yep. And I think that those are the places where it's really important to be very, very crisp about the problem to be solved and what the tools do and also what they don't do. And so there's a real learning component of incorporating new tools into practice, and that's effortful. But I think that the goal really would be tools that help simplify and flatten some of the complexity of what is increasingly this huge set of data that surrounds every person, and find ways to sort of leverage those tools, not so much to see more patients, but to see more of the patient in front of you.
Absolutely. Dr. Clardy, I'd love if you could elaborate on that a little bit. You mentioned this big cloud of data that surrounds each of us. For those of us who aren't data people, explain what you mean.
Yeah, so if you look at medical records and sort of what we have as kind of an electronic health footprint, even over the last 20 years, that's gone from a relatively small amount of person-specific data to a volume of data that's increasing. Sort of health wellness data is one of the largest sectors for data increasing. It's not that it's gone up 100% or 100x since 20 years ago. It's gone up so much that when I tried to make a graph of it, there's too many log jumps for it to look good, right? It's hundreds of thousands of times more data on a per person, per day sort of basis. So I think that one thing is to just acknowledge that health data is multimodal and increasingly complex, and that it suffers from a fragmentation problem. It's scattered in different places and in different sort of formats. And so the ways I think to think about the data challenge in some ways start with addressing data fragmentation. That said, if I said to this panel or to anyone I ever worked with, hey, great news, we figured it out, we got it all in one place, they would say, that sounds terrible. Like, that sounds like I'm already drowning in data, I need more information. And so that's really the second piece, is how do you effectively use new tools to both summarize but also inform kind of what's in that big pile of messy electronic health data. And I think that there's lots of opportunities to sort of think about how to do that. And I think that one of the things that's been really interesting is to see that the barriers to entry in that space have gone way down. And so we collaborate with EHRs, we collaborate with health systems, but the things that you might have said could only be done by a huge company are now things that, tools allow much smaller startups, healthcare companies themselves to use tools to organize data in new ways.
Excellent. And on the topic of data, there are a lot of radiologists joining us tonight, and that is not a coincidence. Dr. Williamson, many AI initiatives have been focused on your specialty, radiology. Why is this?
Yeah, it's a great question, and Pete has already revealed himself to be the data guy, but I'll try this just a little bit. You're exactly right. So take during the kind of the heyday of machine learning, so call it July of 2023-ish, the FDA had, at that point, approved 692, I think, AI algorithms for use in healthcare, right? It's great. 76% of those were radiology, right? You guys were right behind with cardiology. About 11% of those were cardiology. This is not, right? It's not a coincidence. Back in the late 1990s, radiology adopted something called the DICOM standard. Again, radiologists in the room will know what I'm talking about here, right? But essentially, everybody agreed. There were lots of knife fights in elevators at the time, right, about this. But everyone agreed finally with heavy-duty arm twisting that we would all scan things and encode them the same way, so that a CT scan performed in Sioux Falls, South Dakota, or a CT scan performed in Tokyo, Japan, are going to be not exactly interchangeable, but at least communicatable. So you can put, wherever your scan gets done, you can put it on a floppy drive, or you can put it, nobody uses floppies anymore, right? But you can put it on a thumb drive, you can plug it into your computer, probably comes with a viewer, and I can look at it, right? And Ashley can look at it, and we can be looking at the same information, we can make sense of it. This data standard 25 years ago, right, was tremendous, and that's led to the fact, particularly in the machine learning world, that is why the imaging-based AI had a huge head start, right? And it comes back, right, again, to Pete's favorite subject, data. If we can do some of that, I wonder where we're going with regard to large language models. Can we democratize things moving forward and get away from the image-centric and get away from the DICOM standard and start to talk about algorithms that are more focused on human language, right? And that's, again, that's a lot of what we're going to be talking about. But the lessons from radiology for scalability in our new modern age with the new techniques that are coming, right, really is that data access and dealing with the fragmentation and orchestration problems that Pete talks about.
Certainly. Dr. Bisi, at New York Presbyterian, which specialties are seeing the most use from AI tools?
I think it mirrors what Eric was saying. You know, radiology is, with the computer vision tools, is one area where there's a lot of commercial products, the most FDA approved, and looking at triaging, diagnosis. Cardiology is another area where you can segment images to reduce the workload on providers when reading things like echocardiography. And in internal development, what we're thinking about and focus on cardiology to use AI for early detection. So that's another area of interest for ours. And then, like I've already mentioned, reduction in burnout through helping with administrative tasks.
Fantastic. And
yeah, one of the ways, I mean, I think it's really interesting, and would just point out there's a couple of things going on in terms of these examples. Some are related to the technology itself, and that certain constrained tasks, like computer vision tasks, which work well for radiology, there were real changes in the technology and the computing power in the 2012 range. And now we're seeing this new set of tools that have much broader and multimodal capabilities, and I think there will likely be a lag, in terms of some of our understanding of exactly how those can be most effectively platformed. But I wanted to lean in on something else that's come up, which is that a lot of the use cases for AI in healthcare aren't, and probably right now shouldn't be, based on diagnosis or replacing a human in the loop of kind of deciding what the next best action is, but have been designed to sort of facilitate workflows. We did a lot of work with Mayo on radiotherapy and sort of mapping radiotherapy, particularly things like skull-based radiotherapy, requires really complicated sectioning of images that's done by a human, very time-consuming. Designing tools that allow 85, 90, 95% of that to be done by an AI, with the human checking and validating and then completing the task, or using AI for radiology not to overwrite or overread a human radiologist, but reading it to flag cases very early, essentially as soon as they're obtained. So if follow-up images are needed, they can be obtained before the patient leaves the imaging suite. So it's really a queuing system. It's not a diagnostic system, but it's designed around a human sort of care pathway and a human use case.
Right. I'm interested how that would impact patient satisfaction if they're able to get their results and a diagnosis quicker.
Yeah, 100%. And I think one of the things to keep in mind is that some of the gold standard proof points that are expected in medicine are survival endpoints, or endpoints that relate to certain cost metrics. Not prioritized as much historically, though I think much more now. The patient experience, the provider experience, a sustainable provider workforce. These are actually becoming drivers in and of themselves, somewhat separate and aside from things like clinical mortality benefit from an AI system. I think we should look for both, but I think that measuring success is probably not just measuring financial outcomes nor clinical outcomes as we've historically defined them.
You know, Dr. BC, New York Presbyterian is an academic medical center, an AMC, which offers opportunities to teach, to research, to innovate, and they tend to attract physicians with interests beyond clinical care. So what role could AI play in developing a more well-rounded clinician workforce? What would that look like for the industry?
I think that's a great question, Alexis. I'm a little distracted by the idea of doing AI on data that was stored on floppy disks. So moving past that mental picture. But you know, physicians, I may be biased, but I think we are a hardworking, smart, resilient group of people, and the journey on our training is so long. We develop other interests, and those interests could be things like medical education or research or innovation, administration. And I think at academic medical centers, we have the ability to cultivate not just clinicians, but physician leaders in each of these areas. And AI could be the tool or the way we can give physicians that time back or reduce that mental fatigue to allow them to pursue this other or interests beyond just direct clinical care. And I really think it's this other that actually is in part what leads to the progress in medicine.
Dr. Sinski, do you have any thoughts on that from your role in physician well-being?
Sure. Well, the first thing that came to mind when you were speaking, Ashley, was we know from studies that if a physician can spend 20% of their time on their passion, the thing that gives them the most purpose and meaning in their work, that's protective against burnout. And if you spend more than that, that's fine, but it doesn't actually add additional protection. And so we're not asking for everything. We're just needing to have at least 20% of our time be spent on things that are meaningful and or most meaningful to us. And so that's the first thing that comes to my mind when you shared what you did.
Excellent. You know, this isn't healthcare's first go-around with transformative technology. The electronic medical record also promised to make life easier for physicians, and in many ways it did help the healthcare industry. But some doctors have said that it added to their workload. It changed the nature of their work and took them away from those face-to-face interactions, Dr. Clardy, that you mentioned earlier. As such, some doctors are skeptical of new technologies like AI. So, Dr. Clardy, is there any chance that AI will complicate doctors' workflows rather than simplifying them?
Yeah, absolutely. And I think that's why sort of having these discussions is super important. I think that the evolution from sort of handwritten medical notes, which was sort of the way I grew up, and into the EHR has been actually very valuable and rich in many ways in terms of sort of better documentation. There are lots of ways in which sort of solving for some of the data fragmentation problems, you know, EHRs have really been a big step forward. I think many people experience them, as I did, as struggling under the weight of new data sources and data types, and that there's a sort of a fundamental challenge, which is that medical records are organized by data type, but clinicians don't really think that way. And so the effort required with increasingly complicated medical records to go from a series of notes, labs, reports, something called a media folder, which is a bunch of scanned documents and things that you probably need to see but probably won't look at, to something that's organized more around disease concepts that could be explored. So I actually see a lot of opportunity in this sort of space of complex information organization and presentation that happens sort of side by side with the evolution of the electronic health record. I think that the thing that I would probably reflect on that is most important in terms of the implementation side is to just be really explicit about what problem you're trying to solve for and what the new tools are doing. And that from a very simplistic perspective, decision making and sort of clinical processes fall into sort of a big category of tools that we need for assessment, get me up to right now. Tools that might be useful for decision making, what's the right next thing to do, and how do I weight the risks of that? And then something that's like an action, a work product. Some people just go to the OR and do an operation. Most of us write a note or a letter or something like that. So sort of thinking about where is technology helping? Is it an assistive tool? Is it a decision-making tool? Is it a work output tool? I think that helps to flatten some of the complexity of what problem we're trying to solve, and I think it also frames it into what would you expect your EHR to do versus what would you expect a human to do, or where would we sort of need to be very explicit that we might be crossing the line from a information organization tool to a medical device, and that it's very easy with new technology to make a medical device without realizing it, and so I think that's one of the other reasons why being very explicit about your use case and what problem you're trying to solve is kind of the fundamental question.
Sure.
I think there's really some great learnings that we can take from the first wave of technology innovation in healthcare, the electronic health record. And I observed that many people, we were in the hype phase of the EHR, and so that was going to fix everything. And we weren't going to fix other systemic problems because the EHR would fix that. And I hear that again now, only I think it's another order of magnitude greater. The hype and the realistic expectation, I think, around AI is so much greater. But there's also, well, we don't have to actually fix the inbox problem because AI is going to come in and fix that, when technology isn't always the solution to the problems that have come from technology or that are associated with it. And so there's a lot we can do by going upstream to reduce the volume of inbox in the first place, by how we route our information flow, by how we handle workflows for our patients. And it doesn't all have to be solved by an AI application downstream. Some of it is upstream from that. And so I think there's just a lot we can learn. We had this great work transfer with the onset of the electronic health record. We were going to save all kinds of money on lesser trained individuals by putting all this new work on our physicians. And so I think that skepticism, Alexis, that you mentioned, comes from these battle wounds, if you will, that many physicians of a certain age have gone through, where suddenly work that previously had been capably done by many other members of the healthcare team, the receptionists, transcriptionists, the pharmacists, became the physician's responsibility because it seemed like it would be so easy. And I fear that we might go down that same path with some of our AI applications.
That's a great point, Dr. Sinsky. And Dr. DiRienzo said it. Everybody's talking about AI. I'm curious what the rest of the panel thinks about this hype cycle. Are we running any risks by the amount of promise that we're giving AI?
Yeah, it's a great question. We had a little bit of this conversation, while we were backstage among the panelists. I think that for most of us who are, and this, Chris, this goes back to your point, right, who've lived through the EHR and then saw machine learning kind of come in, and we watched that hype cycle, right, where machine learning is going to fix everything. It's going to do absolutely everything for you. This is a disaster. Nothing works. This is terrible. It's never going to do anything. And as we were kind of trending into number 2 and then coming back, the hype cycle ends up at a period of equilibrium where we identify what problems we can meaningfully solve and which ones are a little bit outside of the scope of this particular set of tools. Just about that time as it felt like we were kind of settling into that, large language models and generative AI hit again, and boom, it feels like we've taken off again with regard to the hype cycle. And again, it's something we've worked through before. We'll work through it again. We just need to, make sure that we understand, as Pete mentioned, what's the question you're trying to solve? Okay, is this a tool to do it? Okay, sounds good. Let's scope this, and then let's talk about what is realistic here. But I think we are hyping, but I'm ready to be hopeful again. So.
I think it's safe to say I'm cautiously optimistic. That's
true.
I think,
true.
There's tangible benefits that we're seeing. I think that those will continue to grow with the use of the technology. I think large language models being democratized in commercial is an interesting opportunity for providers to be participants in the development if they have access to these tools in ways that they didn't before, and so that they can help in the innovation process. This skepticism comes in some of the topics we mentioned before about the electronic health record. We want to use AI to help us interpret and process all of the data that's in the electronic health record, but also what we're doing with some of this AI work is delivering more data into the electronic health record. So there's the risk of more digital clutter and creating more burnout by adding information that a provider would need to review and synthesize. And so I think we just need to be incredibly diligent about the way we design and implement the workflows built around this, the care pathways to support evaluation of the data and getting the patient the care they need based on the results that we're presenting.
Yeah, I mean, I think my answer to that question is, are we in the midst of a hype cycle? Yes. Is the new technology, does it have the capability to be transformative and to impact health on a global scale? Also, yes. And I think that that's probably somewhat measured through tools that are sort of provider-facing, but also likely to be measured in terms of patient engagement, democratization of things like clinical trials, sort of information as a social determinant. And so I think those are places somewhat separate and aside from the processes of care where I think there are reasons to be really optimistic, but also reasons to be very clear-eyed about the fact that these are brand new tools, and we don't have an evaluation framework for understanding necessarily right now what good looks like, which is why opportunities in areas that are safer than the sharp edge of clinical care, it makes a lot of sense, but in terms of impact over time, I think it will be transformative.
Sure. Give us an idea of how new these tools are. When you say AI is in its infancy, how young?
Well, I'll give a kind of a slightly nerdier answer than maybe the panel was hoping for, but like a lot of information science, the fundamentals were kind of worked out by Claude Shannon and other people in terms of how you can make all different kinds of information into sort of mathematical concepts. This is something from the 50s and 60s. I think that the evolution of AI in terms of supervised and now unsupervised learning, to Eric's point, has seen sort of the first inflection in the mid 2010, 2012 range with things like Word2Vec, which was a huge step forward in translation and a lot of other tasks. And now with GPT, Gemini, large models. We call them large language models, but they're increasingly large multimodal models. This is a last couple of years sort of phenomenon. I think one of the things that gave me a little bit of a sense of the rate of change was work that we did on a medically trained large language model called MedPalm that was kind of developed from a large model at Google and then essentially taken to medical school, trained on medical data, medical question answering, and then sort of was able to pass the boards at a rate of like 67%, low pass, first time that you had multiple choice, sort of passing grade. And that was super cool, and it's an interesting benchmark. It's not necessarily super useful for clinical care. Like, my practice, unfortunately, wasn't a series of multiple choice questions, but it was a very useful benchmark. And then, essentially, like over the holiday break, they retrained it, and it got like an 87. And that's a really high score on the boards. And I think that was the time where I was like, that's very fast progress. That was, I think, for me, kind of a moment where I was like, that's very different from what I would have expected.
Certainly. It is moving fast, and many of these tools, though, are still in pilot phases. They're still being tested at health systems. Certain specialties have yet to adopt it, and some doctors do choose not to use it when it's placed in front of them. Dr. Sinski, how much autonomy do you believe physicians should have when choosing whether or not they use an AI tool or which tool they use?
Sure. Well, if you don't mind, I'd like to just begin by giving an example of how little autonomy many physicians currently have. And this is an example from ambulatory practice, so our physicians who are in an outpatient practice. I have visited 2 different large health systems where they each did the same innovation, and they gave their ambulatory physicians control over one 20-minute slot out of their day, so one appointment slot. They could use it to call a patient, to see another patient, to catch up on their inbox, or to go to the bathroom. And having control over that 120 minutes was transformative for those physicians. So that's how little control over one's day that you have. And I think about Daniel Pink, who helped us understand the importance of autonomy, mastery, and purpose. Autonomy, you take these highly, highly trained individuals and you put them in roles where they have no control at all over their work environment, and that's a recipe for burnout. Mastery, the exploding information that you've talked about, if we don't have a way to corral that and to make knowledge out of information, we don't have mastery. But if these tools will help us become better doctors, be more, have better mastery over our work, well, then that's just terrific. And purpose, of course, being a physician is chock full of purpose. I don't know of a more meaningful profession. So if half, or at times over half of our physicians have been experiencing burnout, again, I think that shows the system is where the problem is. And so should physicians have autonomy over which tool their organization buys? I certainly don't think most of us have a clue what would be the appropriate AI tool to use. But I do think physicians need to have some level of autonomy that may be, I'm going to do my documentation with, I'm going to type, I'm going to dictate, I'm going to have an AI documentation draft. I'll respond to all my inboxes uniquely, or messages, or I'll have the AI draft it. That's the level at which I think we ought to allow for individual differences. And I think that we've really erred on the side of standardization versus customization, and so our physicians and others are straitjacketed in a very standard work environment, and there are opportunities to provide some level of customization for the individual patient and for the individual physician or other clinician, and we just need the wisdom to discern which one of those is appropriate to which circumstance.
Absolutely. So our question here tonight is AI the cure for Dr. Burnout? We probably won't answer it. We'll let you get a glass of champagne and discuss amongst yourselves. But I think we could all agree that there's no silver bullet for an issue as complicated as burnout in doctors, some of our most well-trained, most well-educated people in our society. So let's say AI does effectively alleviate administrative burdens. Which problems are still left to solve for in doctors' day-to-day lives? And how do we reframe those conversations about Dr. Burnout?
Well, Ashley mentioned my favorite one, which is access, right? And we're looking at, just take a very, very basic example from my life, right? From radiology. We know that there are tools, AI-enabled tools, that can allow for at least an initial interpretation of a chest X-ray, let's say. So do you deploy that algorithm into a busy hospital in the United States where there are certainly issues around access, or do you deploy that in someplace like South Africa where there are 1.5 radiologists per million inhabitants, right? That's an absurd number, right? The access challenges that I run into, which I would argue are manifest, frankly, pale by comparison, right? What's the number in I think it's 30 or 50 radiologists per million people in this country. There are opportunities for us to address not just local access issues, but potentially, eventually, really global access issues. Super exciting time, frankly. I'm not saying we're there yet, but it's a super exciting time for us to be planning for.
I think as a cardiologist, one of the things I think is interesting is what we're looking at now is early identification of disease, but can we take that one step further? Can we identify patients that are at risk for disease? Can we use the technology to identify gaps in management and make recommendations and bring that to the forefront? Can we take not just one modality of data, Pete, like electrocardiography or echocardiography? Can we combine data that's now viewed in silos in a multimodal way to really bring out insights that me as a physician, maybe someone who reads echocardiography, or like you, Eric, other cardiac imaging, and really get insights and see things that the human may not.
Fantastic. Well, thank you to all of our panelists for their insights today. Appreciate it. And now we'll be transitioning into the question and answer portion of our discussion. So if you have a question for our panelists, please raise your hand and a microphone will be brought to you. We're going to start over on this side that I have not been facing all night, right here.
Thank you so much for the very interesting discussion. I'm a computer scientist. I work in radiology. I make tools for radiologists, right?
Nice.
And I hear from my physician colleagues a lot of complaints about the burnout. So sitting here and listening to the discussion, I can't help by wondering, perhaps a little philosophically, to which extent do you think AI is treating the symptoms, if it's going to help, of a broken system? Mm-hmm. And to which extent do you think it can cure the broken system? As you mentioned in the beginning, the burnout is the manifestation of a broken system. So how can we get to the system versus just the symptoms?
Do you mind if I start with that and then turn
sure.
it over to the rest?
Absolutely.
I think you're right. We have a broken system, and I don't know that we've identified one of the most serious components of that break. I think we have evolved to a very transactional understanding of what healthcare is. And it's a series of disconnected episodes that can be delivered by anyone, or even perhaps anything. But that at its core, our work is relational. And we are better healers, we are better diagnosticians if our work is founded on a relationship with our team members and with our patients. And so can AI help us have more time to build relationships? That's the positive. Or does AI contribute to this transactional understanding of healthcare and anybody will do, and further disconnect us from relationships? So I'd like to see a radical reorientation of the healthcare system to one that prioritizes relationships, continuity with our patients, and continuity stable teams with our team members. And to the extent that that's what's broken, AI can fix some of it, but it won't fix it if we don't have the appropriate understanding of what its purpose is, or what one of its purposes is, or what problem are we trying to solve. And one of the problems should be we need to restore the primacy of relationships as part of the healthcare experience.
We have another question up here in the front.
To what extent do we risk slowing the development of AI or the adoption of AI by insisting on perfection, in many cases having zero tolerance for error, when my world, a lot of doing ambient documentation, the notes may not be perfect, there may be some hallucination in there, but you're not comparing it to perfect, you're comparing it to the tired doctor who's finishing his notes at the end of the day. Or in radiology, you may be comparing it to no radiologist at all.
Yep.
And to what extent would the, even a lower performing model be better than that? So I would be interested in your comments on just how we, live with an imperfect tool, and how do we, create acceptance for patients and doctors in that world.
I could actually start there. And, I would say I think that I completely agree with you that the comparison should be what is the standard now. Medicine's a very evidence-based field. I think we need to do a better job in, doing studies and evaluations, and not just look at the technical performance of a model or a solution, but really what does that solution look like in the whole healthcare system once it's integrated, because there's a lot of variables that'll affect whether we achieve that outcome, and compare that to the baseline. I think that we need to, like I said, just get more data, do these trials, and be aware that we're not going to understand every risk, right? There's a lot of unknowns, whether it's related to health equity and bias, or how a model's changing over time, or the data, or the interaction between models. And so we do need to do more evaluations to understand those unknowns and accept some level of risk.
I think your point, though, is well taken, like compared to what? And I think even if you look at highly constrained tasks, like on this image, is diabetic retinopathy present, and if so, is it mild or moderate? Like when we sort of built the systems to evaluate that and worked with a lot of experts, like adjudicating those is non-trivial. And so even something that you would say, well, there's a gold standard in this image, it's hard sometimes to get to full, perfect agreement on that. And so that's why in the framing of what problem you're trying to solve, if the problem you're trying to solve is it's really hard to kind of find information all over the record and write a draft of an admission note, well, then sort of what a good draft of admission note looks like compared to an admission note you would sign after kind of review, examining the patient, considering sort of pros and cons, maybe looking at some of those details, is very, very different. And so sort of operationalizing things that are labor saving, if we've designed this as a assistive workflow tool, then I think you can sort of think of a gold standard that's just, it helps me do it faster. In that middle spot of tools for decision making, there I think you can't really frame it as a draft writing tool, right? If it's putting a list in front of a human, there is a framing effect there, and there is also kind of a real need for a human in a diagnostic loop to be doing something a little bit different than proofreading. Some of these are somewhat subtle distinctions, but I think it always comes back to the use case, and then the proof point sort of follows downstream from the use case, as opposed to proof point follows from, well, it's a large language model, so we evaluate it this way, or it's a machine learning tool, so we evaluate it that way. It's much more nuanced and sort of, I think, use case specific.
We have another question up here in the front.
So one of my favorite comedians is George Carlin. He says, think of the intelligence of the average person, think half of them are dumber than that. So we're talking here about physicians and their knowledge, but ultimately, we ultimately need to explain this to our patients. So I don't know how the tools that we're developing do a better job explaining, depending on the generation that the patient is part of. The other issue is on the other side with the payers, they're using AI to refuse payment. And going to radiology and cardiology, I'm an otolaryngologist.
Ooh.
Not everything is imageable.
Wait.
Just letting you know. So,
That was not my understanding.
I understand. When you get a negative MRI for a migraine and you explain that the headache is
Yes,
not due to
right.
that,
Cannot
you
rule
still
out
end up
headache.
having to have a
Yeah.
conversation with the person. So the question becomes, is the other side's using AI,
Yeah.
and they're going to be using it more and more frequently. We're having less and less physicians providing the care. So some of the garbage in, garbage out is more. Let's just keep it that way. And then the other thing is the end user, the one who's actually deciding whether this care is quality, doesn't necessarily have in this increasingly science de-escalated market an environment that they're actually willing to be taking that information in. Plus, they're dealing now with phone trees where they can't reach the provider at all or the physician. And all of this is creating chaos as opposed to a system. So I don't necessarily see where AI is creating order to this chaos, just another fancy bow in the system. But ultimately, when I end up seeing patients, they just want me to explain what's going on to them in their individual purpose. And I'm glad to meet Dr. Google, but I only have to ultimately have to explain Dr. Google to the patient.
Yep.
So there's a lot here to decouple. I think technology helps, but sometimes it's really the interaction between the one person and the other. And given the amount of steps the patient has to take to come into the office, we're not really fixing that with this.
How do we
Right.
explain AI to the patient?
Yeah, so this is an easy question. Does anyone else want this? No.
Great question.
It's a really difficult and complicated question that you bring up. But I think that, again, it's not so much that the AI in and of itself is solving for any problem, but maybe forcing us to be a little bit more specific about these processes of care, because it's not only that the patient has so much to do to kind of get ready for that encounter, but you do too, right? And we were using the phrase backstage is like physician as data mule, right? Like the job has gotten so complicated because of these workflows you describe of like, I got to pull this from there and this from there, and trying to get all that information has taken away the thing that's actually most special, which is your ability to connect with the other person.
And you wonder why we feel burnout when we're called data mules.
Yeah, well, no, this is exactly the challenge that I think clinicians face every day is that, and what I would say where it's not that burnout is more common because we have a less resilient group of physicians right now. That's absolutely not the problem. It's that the conditions of work have changed in such a way that the job as it's intended to be done, the job we know we should be doing, and the job we have to do are two different, right? That's where I think burnout comes from.
And I think,
Oh, sorry, no.
I was just going to say that I think it's a healthcare system's responsibility to provide their clinicians with the tools to explain the technology to patients, whether that's in things like model cards, if there's an AI model, how was the model built, be transparent about it, what data was used to train it so that they can explain the applicability and the risks and benefits to their patients.
So now you're playing the optimist. The other thing that you mentioned as a part of your question was the number of claims denials. And we know that AI is contributing to an increased number of claims denials. And yet, who ends up adjudicating, and I can't remember what the number is, a very high number actually get overturned once they're challenged, right? There's a claims denial, but we're going to go through everything, know that was really indicated, and we can overturn those things. That requires human effort on the part of the provider, right? Whereas we have AI screening on the front end to deny more frequently than was occurring previously. This is definitely an unintended consequence. I think if most people talked about what are the influences of AI, large language models in the healthcare space, I think very few people would say, oh, you're going to see an increase in claims denials. When you're, wait a second, what? That's definitely something that we have to solve, right? And you want to talk about a system problem. This is part of a big system that needs to be fixed.
Great question. We have time for one more here in the back. They're coming.
Before EMR, we had 1 page of illegible note. With EMR, we have 10 page of very legible, but mostly nonsensical notes,
Right.
where you have to spend now a lot of time to find half a page worth of relevant information in that 10-page note. So, Dr. Google, what do you think AI will do More data is not always good.
No, I would completely agree. And more data and more screen time, I think, are the things that you want to solve for. Like, how do you get less time in front of the computer? And I think the idea there is that this language of medicine, multimodal, very complicated, growing, it's images, it's waveforms, it's a lot of text, and the tools we have right now are not up to the challenge. And so I think rethinking what we mean when we say sort of tools for managing information, it doesn't mean everything goes into a lab's vitals, notes. That's not really meeting the challenge as it's currently experienced. And so that's actually ends up being a lot of what I think we're interested in sort of thinking about in sort of looking at natural language processing and OCR and organizing medical records in a more intuitive way for providers to explore. But I think your point is absolutely well taken, is that we've now got extremely long and comprehensive medical documentation, and it's still a major forest for the trees problem. You still honestly have no idea what's going on a lot of times when you're at the end of that note, and it's because it's cobbled together from templated stuff, copy-pasted stuff, some new ideas, some old ideas, a bunch of stuff that gets rolled forward. That's actually causes these records to be very recursive and messy. There's still a lot of information encoded in these overly long notes. And so I think that's part of the challenge, is how do you boil that down into a representation that's clinically useful and explorable, but also usable within a clinical context.
Certainly. That is unfortunately all of the time that we have for tonight. But thank you to the audience for your great questions and engagement tonight. And Dr. Clardy, Dr. Sinsky, Dr. Bisi, Dr. Williamson, thank you for being here.
Thank you.
This concludes tonight's discussion. Thank you again to all of our speakers, the Hospital for Special Surgery, and our virtual and in-person attendees. For those here in New York, please enjoy this evening's cocktail reception and have a wonderful evening.